I'd like to welcome you to the session of the International Society of Bilateral Cataract Surgeons on bilateral cataract surgery. Before we start the session, I'll tell you that our society was really founded when, in about 2002 or 3, a number of us were doing bilateral surgery and were concerned that we didn't know who else was, and there was no society promoting or talking about it. And so we got together at usually the ESCRS, maybe 3 or 4 of us, 5 and then 6, and we would talk about bilateral surgery, and then we would try to encourage others from different countries to join us and take part. And we found different places were interesting because, for example, Finland even then was doing almost half their cases bilateral surgery. We found that they had done a study in Spain where the government was interested in showing that bilateral surgery was as safe or not as safe as separate surgery. And so we met some of them. As we went on, we began to get a significant group and decided to get organized. And in 2009, 2008, we got organized as a society. And so we've been going for over 10 years. And the interesting thing is that in many places, for example, the US, the place that was most resistant to bilateral surgery, as of about 3 or 4 years ago, almost all places that weren't losing money by doing bilateral surgery were converting to doing bilateral surgery. And so in Colorado and in Northern California, where they have HMOs, they were interested in doing bilateral surgery. And we haven't found yet a single publication where we showed an increased risk of bilateral surgery, just either the same or lower risk. So we decided to have these sessions, and Cyrus has been very active in encouraging us to come to India, to encourage Indians to look at doing bilateral surgery because of the huge backlog of surgery and the obvious benefits for the patients. So, with that, we'll start the session. Anyone have any questions first about the society or anything else? No? Okay. All right, so welcome to our symposium. I'm Steve Arshinoff from Toronto, Canada. And the session this morning, I will introduce bilateral surgery and give you a rationale of why just about all of us who use it decide to start doing bilateral surgery and how we found it among our patients and our results. And after I introduce the topic, we're going to have some excellent speakers, some local, some foreign, talking about different kinds of situations for bilateral cataract surgery, Dr. Cyrus Mehta, Dr. Bojan Pajic, Dr. Mayapal Sachdev, and Dr. Keki Mehta. And then afterwards, Dr. Lalit Verma, a retina surgeon, will either be positive or negative about our bilateral surgery. We'll wait and see what he says. So with that, I was given the topic, or I guess I chose it, the rationale of why we perform bilateral cataract surgery. So in my own case, my first case was a person who was a 35-year-old female who races cars. And she came to Toronto asking for bilateral surgery because I guess she hit her head a few times and had cataracts. And I told her about the risks, and she said, well, she has no time to do it separately, and the risk of doing bilateral surgery was much lower than the risk of racing cars. So I thought that actually made sense, and so we did her, and since then, the next day, all the patients who saw her having had both eyes done, and them having had one eye done, they asked me why I wasn't doing them also as bilateral surgery. They were forced to come back. So we began to do more and more cases. So it's interesting. So the bottom line is, I feel strongly, I think most of us do who belong to our society, that it's just better for the patient. And that's why we do bilateral surgery. It's interesting how it started, and you may have heard this before, but in April 8th, 1747, Jacques Daviel performed his first planned extracapsular cataract surgery. But he did it as bilateral surgery. And he did the left eye first, which is interesting because I always do the left eye first. And he found that by 1756, he'd done 434 extra caps, in which almost all, 89%, were successful, which is pretty good for 1700s. And he did a lot of bilateral cataract surgery. So we're not the originators of the idea, but as technology gets better, it becomes easier for us. So my own story is, I started doing these routinely in 1996. I did a few before, like I did a lady in the early 80s who had bilateral white cataracts and TB, and they wouldn't do her because they thought active TB would infect the operating room, and so I did her both eyes together, and she was perfectly fine afterwards. So I've done about 80% of all my cases bilateral surgery for the last 20 plus years, and the reason it's 79 is because sometimes the hospital makes me do one eye on Wednesday and one on Thursday, because they don't want to do bilateral surgery because the government doesn't fund them for bilaterals for that month. So I did some that were unilaterals. I also like to use intracameral Vigamox. I think it's critical that we use an intracameral antibiotic during bilateral surgery. So our society has one very important rule, that if you have an unresolved complication in the first eye, you should defer the second eye. But the other alternative thing is, from my experience, and I think all of us, is by far the best time to operate someone's second eye is just after you've finished the first eye, because everybody's eye is a bit unique, and people that are a bit strange and have funny things that you find, whatever it may be, you find the second eye is much easier because you can adjust a bit for it. And so we have to balance these things and decide whether we're going to defer a patient or not defer them. And most patients I've deferred have been things like their back hurts too much and they can't lie still, and not really anything from their eye, because the eyes have done extremely well. So I have some comments about some pearls I could tell you about experience I've had in bilateral surgery and what I think works better and why I think it's important. And the first thing is that when a new cataract patient comes into you, we always assume they're coming for their bad eye. But the truth is, when I find patients, a lot of them complain to me if I do one eye, and they're complaining because it's the better eye they were complaining about. Most people that are 7 to 80, they don't come in and tell you that my right eye is bad. They come in, they say, I can't see. And when they say they can't see, they mean the good eye. And so if you just do the bad eye, I've had many patients when I was doing unilateral surgery, and since some that want unilateral surgery, tell me, well, doc, I mean, you fix this eye, but I still can't see out of the other one. And they're actually unhappy because they think the eye that they didn't operate on got worse. So that doesn't happen during bilateral surgery because they sit up, they can see in both eyes. Next thing is that there's fewer visits, and so patients and their families really appreciate having bilateral surgery. They don't lose binocularity. There were some studies from Europe showing that when you do two eyes separately, the patient really has some loss of binocularity, which can last up to 4 months. So you see fewer falls, accidents. The patients just adapt better to their life, and you get overwhelming preference for doctors, lawyers, anybody who's busy doesn't want to come now and come back again in a few weeks or whatever for the other eye. And refractive surgical patients always want to do both eyes. The other thing you find is if you use multifocal lenses, or you're going to even change someone from being, let's say, a high myope to an emmetrope or a high hyperope, they adapt much better when you do both eyes. When you change someone's vision drastically in their perception, I warn them that don't go the second day and drive your car out of your garage, because you might take off the side of your garage door when your perception is different. But to walk around first, because even doing bilateral surgery, it changes their perception somewhat. And during unilateral surgery, they really can't do much for a while because they can't adapt to the change in their vision sometimes, especially with multifocal lenses. The other problem I've seen is I've had patients, about 2 or 3 of them now, that have been sent to me because they had some disastrous calamity occur in their first eye and they don't want to have their second eye done. And despite trying to convince them and everything else, I have 2 people that I've been seeing for like 15 years that still keep refusing to have their second eye done. That, of course, never happens if you do bilateral cataract surgery. There have been papers by Javid and others showing that there is more improvement in vision after the second eye is done, more than when the first eye is done. And the other problem is that as we do surgery quicker and quicker, and you have cases that take 10 minutes and 15 minutes, what happens is the operating room staff becomes sort of in a big rush to get the next person in. And I find they're much more cautious when the patient is staying for 2 eyes. And so the results I get are better when I do bilaterals rather than, say, 2 consecutive unilateral patients. And then you have special patients. I have these people agreed to have their pictures shown. This guy, Christopher, is my poster child. He's about 27 years old, and he has muscular dystrophy, and he can't move out of his chair because his bone density is like 10%. And if you lift him up, his bones will all fracture. He has to move with a special lift. It takes about an hour to move him and do anything. And so his mother asked me, we just do both eyes together. The drugs he was taking made him get cataracts. And so I did him, and I did monovision. And one eye could see the television and one eye to read his iPad. And he was 20/20 for far and for near the next day, perfectly happy. Janet is a Down syndrome, and this lady, Susan, is a bit schizophrenic. And so they're not easy patients to do. Their families are very concerned bringing them in, having them get all upset and going through the whole thing twice. And doing them once is much, much easier. And then I get patients that are anesthetic class 4 patients that for some reason can't see to perform in life, and their families ask me to do them, knowing that there's more risk when they're anesthetic class 4, but I'd rather just do both eyes and not put them at risk twice. It doesn't take that long, and the risk is no greater doing both eyes once they're there. I've done some patients who were moribund with cancer, and their families asked to help them see because they really could not see to do anything. And at least if I fix their cataracts, they can see in bed to read while they're lying there for a month or two in the hospital. So there are many cases where there are obvious advantages. And those who have positioning problems, I've done spondylitic patients where the bed is basically tilted like this to get them to be able to see their eye, and they work much better doing bilateral surgery. Next point is, I think it's really critical if you want to take on bilateral surgery to be careful. And I think you have to remember this one critically, because you have to be as careful or more careful in doing unilateral surgery and make sure that everything you do is planned out in advance. So I make sure that everyone who works in the operating room reads our society's publication on the steps to take for have safe bilateral cataract surgery. I make sure that they list all right and left parameters on a board everybody can see in the operating room, so they never hand me the wrong lens. They always check which eye we're doing, which lens, where's the astigmatism in this eye, what exactly we're doing as you go along through the case. I make them do military calls, so when the IOL is handed from person to person, they announce, this is the patient, it's the right eye, this particular lens, so that I hear, and I keep on the microscope every patient's data listed, so I know that as it comes along the path, there's no errors. So I've never had an error with the wrong lens. I do the operations as two independent procedures. I change everything, gloves, gown, all the instruments are changed for the second eye. And if you have any complication that you're worried about for the first eye, you should defer that eye till later. So my only changes I've had after doing this for over 20 years is my exclusions that we list on our society sheet have actually been reduced, because I find that it doesn't make any difference if someone has diabetic retinopathy. If you do both sides or one, they're still going to get the same problems. And often the retina surgeons were sending me patients because they couldn't see the retina. So if they can't see the retina to do vitrectomy, I might as well do both eyes rather than have one eye wait for longer. And so I'm left to doing only unilateral surgery in borderline corneas and in patients who are septic. Obviously, I don't want to do surgery. But otherwise, I do them. In femto cases, we initially used to do femto-phaco, so we do one eye at a time. But then I had a patient who came in and she was nervous. So when I was doing her first eye, the anesthetist gave her a shot of anesthetic when she was lying down for the phaco part of the procedure. And when she got up to go back to the femto, she fell over, despite the nurse holding each arm. And then I thought, you know, it's probably a lot safer to do both eyes femto first than have patients fall over walking back and forth 10 feet, because they may really get hurt, because they're not very young sometimes. And I got that, I was talking to Laurent Lalonde, who's in Boisbriand, Quebec, and he began doing this in 2014, which was before me. I started about 2 years ago. And he's done many, many cases and doesn't talk about it too much because everybody criticizes him. But I think it's better to do femto, phaco, because there's almost never a circumstance where you'd want to defer the second eye. So next thing is, part of being careful, use intracameral drugs. It's been shown everywhere in the world in every study that reduces infection rates. It's not excessively expensive. In the US it costs $20 per eye, but that's a unique country where they charge a lot for these drugs and have different rules. In Canada it costs us less than $2 per eye, and I use moxifloxacin, 600 micrograms diluted in 0.4 cc's, for reasons I said yesterday and I'll say later in another lecture. I just think it's better. So use our accepted terminology. So ISBCS, all capital letters, stands for the procedure. The small italicized I stands for our society. It's just a coincidence it ended up being the same letters. It wasn't planned that way, it just happened. And DSBCS is delayed sequential bilateral cataract surgery if you plan to do both eyes and do one today and one next week or whatever. Then when you read articles that talk about how dangerous bilateral surgery is, be suspicious, because almost all those who write those articles have an agenda to be against bilateral surgery. And when you look at them carefully, you find that what they're saying isn't really true. So the complaints that we're going to blind the world, well, the real reality of the infection rate we've seen in our study of our society of bilateral cataract surgery would be for bilateral simultaneous endophthalmitis about 1 in 250 million. So it's not particularly likely you're going to get a bilateral infection if you're cautious and you follow all of our recommendations. And the comments also on the improved refractive result, if you do changes for the second eye after the first eye, assumes that one, both eyes are the same, which often they're not when you get different results for different lenses, different eyes. And it also assumes that you're using older technology. As we get newer and newer machines and newer equations, the risk of errors goes down and down, and I think that changing to the second eye may lead to error as well as it may lead to a better result, unless you know why you made a mistake in the first time. It's interesting for me to observe that India is now one of the top 5 countries in the world in doing bilateral cataract surgery. In our society, the countries with the most members are now surprisingly Americans. The Americans have adopted it quite effectively since they found out they can do it without losing money. And Canada is second, and then United Kingdom, Spain, and India. India and Spain are more or less tied in terms of how many do bilateral surgery. So the last pearl is, I think that if you're going to do bilateral surgery, you should join our society. You should take part, because we only find out about problems in medicine and in life if we talk to each other. This is the only society where we try to collect data from different people and look at studies sometimes and have sessions about bilateral cataract surgery. And so I think taking part is very important. So thank you very much.